Started. So there we go. And I want to welcome everyone today, and I hope everyone is well. We've kind of been sharing war stories of our own illnesses over the past few weeks, but do hope that you're well and staff as well. I know it's quite the struggle throughout Indiana right now with flu and COVID and other respiratory issues going on. So really appreciate your time today. I'm Becky Royer. I am the lead for the Medicare Beneficiary Quality Improvement Project for the State Office of Rural Health, who contracts CAH to lead this type of work. You've joined the Swingbed webinar today, which we will be having them every other month going forward rather than every month, and conducting them at 11 o'clock for around 45 minutes. But again, always reach out anytime you have issues or questions coming up. We have lots of hospitals building their swing bed programs, and more than willing to assist you in doing that. As always, our guest speaker for today is Kerry Dunning, who's a national post-acute care expert, and she has conducted education throughout the country and internationally on skilled care types of settings, and just has really been a great resource for our organization over the past several years. Everyone should have received the document yesterday that I'm sharing on the screen titled Indiana Case Study, December 2022. Kerry's going to be providing that information on this case study today. So please feel free to pull that up for reference if you would like to. Without further ado, I will turn it over to Kerry and we'll get started with today's program.
Thanks, Becky. As Becky said, we're going to every other month, and with that thought process, I thought we would change up how we are using this hour of your time. There may be some times where we have to spend the entire hour because of updates. I mean, that's just the given. If you looked at the October regulations, that never in my life before have I seen them put on October 1 that they're published and will be available, and you're supposed to follow them by October 24, and then they changed them 2 more times in October. That seems to be what's going on. So we will spend some time on highlights. But I have set up today to do a couple of things. First of all, this is reproducible, so you can use this format or something like it for your own team. This doesn't have to be, you know, a one-off, that if you have new employees or others, or you're trying to figure out what's going on, then something like this can be used or amended to your use. Second, I have picked for this first one, sort of just like we were talking about COVID, flu, and what's even the third one? I can't even think right now, but RSV. We're in this swirl of things, and there is a lot of conversations at a national level, and thus at a survey level, about what we call the big 3, which is the trauma-informed care, infection control and prevention, and person-centered care. What's interesting is that we talk more publicly about the infection control and prevention. I think partially because that impacts all healthcare settings, not just skilled, your hospitals, your outpatient settings. Everybody's been paying attention to it. And since it's been around since 2016. The other 2 are more skilled nursing related. It applies to all settings, but the rules that we're talking about are skilled nursing, which the swing beds fall under those directives. And they came about in 2019, which of course 2020 was sort of the end of us paying attention to paperwork and more into reality of taking care of patients there for a couple of years. So on June 29 of this year, 2022, CMS revised the surveyor's guidelines on infection prevention and control, and that's why this is coming up. And then on October 24 of this year is when the other 2 took more front stage, the trauma-informed care and person-centered care, in the guidance that's closer to, it's somewhere, I mean, they keep changing, but it's around 856 pages at this point. And so to cut it down to these 3, I wanted to see how you guys are handling, if you feel comfortable, that your team has the knowledge, if there's training that we specifically need to do with this. The importance of this is that there are, I think at this point, it's probably 5 F tags. 5 F tags are federal tags that you can be cited on in nursing homes that are directly related to this. So I sent this out, or had Becky asked Becky to send this out as an advance so you can look at it. It's a pretty simple case study. It's not meant to be complicated, but it is meant to ask you how you can address this. What is the paper trail, the regulation trail, the training available in your facility where if such a patient walked in, that the right steps would be taken, for instance, addressing an IDT. So Becky, I don't know if you got a chance, but I'd also ask that you double check afterwards with what you learned today on what is your policy that's written for each of these 3 specifically for your Swingbed program. What does your admission assessment include that would address these 3 issues as we go through this? Is there something very specific in your baseline care plan, again, to anything involving these 3? And does your IDT note routinely note the things that you have covered specific to these areas again? So those are areas for review. And so what this is pretty simple. It's a very poor behaving 57-year-old male. So I picked a younger patient because they can be rowdier these days, and someone who's not happy because he still has back pain and headaches and doesn't want to be in the hospital, and he's resisting training and staffing. Is probably being not so polite anytime a staff member is trying to ask him a question. And my favorite part of this is he goes to therapy complaining about nurses, and then he tells the nurses that the therapists are mean, because I don't know how many patients we've seen in our past lives that kind of fill that. So in the initial IDT, you might pull down to that next paragraph a little bit, Becky. In the initial IDT, what would be discussed and how are things reviewed? So you have a troublemaker, and what trauma-informed care and person-centered care are now asking us to consider is what's prompting that. And are you using an ACE? Are you using another standardized test? Or what approach would you take towards this patient? Because you need to address in IDT, not just your discharge, not just your physical ailments, but is acting out, refusing care, aggression, and then going back with this. And there's a chance that the infection control prevention has a medical issue here for him to be dealing with either. So this is an open-ended question, and I would love input from any and all of you if you are now considering particularly the trauma-informed care and person-centered care when you are writing your initial assessment, when you're interviewing, admitting a patient, and then third, is your IDT structured now, that this is a question that stays on, these 2 things stay on the table while you are talking about the physical and mental health of the patients that you're dealing with. So Becky, I'll let you see if anybody wants to be brave and ask about this, talk about this, own up to whether they have a policy for these 3 or if it's in their admission assessment or not, because that will give us information where to kind of head this going forward throughout this year, these particular topics.
Yeah, and please feel free to unmute your line by hovering at the bottom of your screen. For most computers, it may be at the top, and unmute your line and just share, just if you're willing to, just information around your internal policies and procedures and how you approach these particular types of issues.
Becky, I'll volunteer.
Thank you.
I'll be brave.
Good, good.
We just put in place a trauma-informed care policy last year, and our social worker developed it. And, you know, she did put in there, like, a way of thinking and interventions that are directed by a thorough understanding of the profound neurological, biological, physiological, and social effects of trauma. And and there's a lot more to the policy, but what we do is we do a psychosocial assessment, and our social worker does that. And she goes in one-on-one and talks to the patient to try to kind of get a background and find out what his this person's issues would have been, or his preference for his care, and just tries to come up and share that with our in our interdepartmental meetings. And we actually have a meeting every day with the interdepartmental department every day at 10 o'clock. So we address a lot of these issues in that meeting to see if we can problem solve in some way to help this gentleman participate.
So first of all, that's a perfect approach to this. Second of all, I hope you're documenting all this effort. It doesn't have to be the great American novel, but putting in, you know, obviously you have the social workers' notes, but that what your team has decided, you know, in a paragraph or whatever from the discussion related to this would be important also. And I forgot to mention, Sudhi, and you probably already take this in account, there is not a human being on earth that hasn't had trauma. And all I have to do is say pandemic, and we have recent trauma that has impacted substantial numbers in our community because they've been isolated, because they got sick and couldn't get help, whatever the issues might be. So the second part of this that's in the regulations then is making sure your own staff has had the training, not only to take care of patients, but also to how do we address any trauma that they think is in their background, but a patient can bring to the forefront very quickly. Does that make sense?
Yes. And we do health stream for our education for our staff.
Okay.
And that was included into our health stream education, so that all staff members have to complete that. So that right now, that's the only educational link we have to teaching people how to deal with it.
You know, a suggestion, everybody's got to do it their own way. Sizes of staffs make difference. You know, our daily interaction in a smaller hospital with all staff is more possible than a large departmentalized, you know, hospital system. The question is how we prompt our employees to be paying attention to when they are feeling something that a patient has set off. You've worked in healthcare, I'll say for at least 5 years. I'll be kind. I don't know how old both of us are, but you've been around and long enough. And
30 years.
There you go.
A long time.
So in 30 years, more than one patient has set off something within you, you know, because that's just the nature of our games. So, you know, the Disney way, which is really wonderful if you're in entertainment and not in healthcare, but it works. One of the things Disney did from the very beginning is if somebody's having a bad day, I'll use Disney World as an example because that's where I trained, but you can go to your supervisor and say, I need a break. And you can go what they call downstairs. They have an underground at Disney World that's for employees only. They have music piped in. They have a place you can sit and get a soda or iced tea or whatever. And they're allowed to go off the premises, you know, off that front entertainment piece and regather themselves, which is a really, really good way when you're dealing with screaming kids and mad parents, et cetera, et cetera. Now, we have the same pressures, but we can't say to our supervisor, I think I'll go get a cup of coffee for 15 minutes, you know. So how do we address that in healthcare to one, recognize, to have the staff member recognize it, maybe even say something to you or to a, you know, floor leader or whoever, you know, might be, but help them later after that event has passed. So that's a question that I don't know the common answer to, honestly, Sudie.
Yeah.
And Sudie, there is a request in chat that Linda wondered if you'd be willing to share your policy. And so if you're willing to do that, if you send that to me, why I can get it forwarded to Linda if you're willing to do that.
Yeah, absolutely. Absolutely.
Great, thank you so much. And the other thing I wanted to share, I know I have shared this link with the group before, but it's also hard to keep up on everything. But the National Council for Mental Wellbeing has developed a change package for trauma-informed care called Fostering Resilience and Recovery. And within that change package, and there were some issues with some of the video links, but those have all been corrected. But they have some really nice YouTube education videos that can be shared with staff on trauma-informed care too. So in follow-up in sharing today's recording, I will also include the link to this change package. There are some longer videos, there are some shorter videos, but I found them to be very informative, and I think you will for your staff too.
And thank you, Sudie, for opening up there. It helps everybody, I think, start thinking about it. But I'd like to take this same thing and move it towards person-centered care, which is a huge directive in healthcare, but particularly in skilled nursing, because you've got to remember skilled nursing is predominantly nursing homes. Long-term care with skilled nursing units or numbers of patients in those facilities. And so that population, trying to keep things real for them when they've been removed from their home is a difficult task, where those of us working in swing beds have probably two layers of this. One is literally short-term patients that we're sending home, but we also have some that we're sending back to or beginning to discuss with them and a patient representative about sending them to nursing homes because they need more care, and those are difficult times. But this time of year, with the person-centered care, we're in a lot more depression. I don't remember the statistics, but the statistics in December for suicides are just phenomenal because of the holidays and because of people being lonely and because of people not being able to do the things they could do 10 years ago in their lives, whatever that matters. So I don't know what's going on in each of your communities, and I'm certainly in a larger area. I'm also in the South. Jacksonville is a massive city all of a sudden. I know the difference because I try and drive in it these days. But we don't have one religion. We don't even have one language in this area anymore. We have a huge influx of Eastern European individuals who come from different countries and speak different languages. And when I go to the main shopping area in this town, I probably hear English 1 out of 10 people passing me. Now, that may not have impacted your communities as much, but all of us have multiple population, societal backgrounds, racial backgrounds, even, from different countries, whether it was their parents or them directly. So how do we deal with a person-centered care in this time of assessments and IDT meetings? And if somebody else would like to take Sudie off the hook, that would be cool. Becky, I can't hear you. I think you're muted.
And I was just telling people how to unmute. Just make sure you hover at the bottom of your screen. But yeah, very willing to share. And this is a great time to also ask Kerry any other pertinent questions that you have.
I do. We don't have like anything that just actually says patient-centered care. Should we have something that
Yes.
specifically like a flow sheet or we have questions that are patient-centered. They're in our assessment. And I guess we kind of thought it was our care plan.
So you are correct. A facility assessment with questions that have to do with the person and with cultural competence, that language that CMS is using these days. I can take any religion in the world this time of year, and 90% of them have December holidays, for lack of a better word, but religious interventions. But even within those religions, there's different ways that families celebrate those time periods, or if they're more sobering, follow those guidelines. And so what's our sensitivity? I have been around nursing homes for 1,000 years now, and the big thing, other than a series of nursing homes that I work with in South Florida, has always been putting up Christmas decorations, which is great. I mean, the joy around having color and activities and music and so forth. A lot of groups have kids come in and sing Christmas. Well, if we have, and I will tell you the group down south, they're Jewish homes. So I have to, when I was working in rehab, I had to train staff to realize they were going to have their holidays in October, and they probably weren't going to take Christmas Day off in December. So we had to rearrange how our employees worked, because those homes were literally 100% Jewish, and two of them were co-Jewish. So it is realizing, as we have an influx of different races, different ages, different populations, that we may have to stop as a group and say, what's important to everybody that's now with us? Ready to admit somebody to Swingbeds that has a different calendar than us, a different sense of time off than us. And that's where I think the policy becomes important. It can be a global policy. Doesn't have to say specifically, we're going to do 1, 2, 3, for this group or that group, but it needs to say that you're recognizing, and that you're part of your IDT, part of your training will be to be cognizant of the differences in what that individual may believe one way or the other. Does that make sense?
Yes.
Does anybody currently have a policy on person-centered care in place?
I don't believe we do. Not specifically.
And
Right.
even if you want to chat in, just open up the chat function and just let us know. And if you do, I bet that's another policy that people would be very interested in sharing.
Becky, I'm going to look too. I'll send on that one.
Okay. Kerry, as you spoke and you were talking about cultural competency, would you mind elaborating on and how an organization has really structured a good cultural competency education to make sure that individuals on staff really do have the information that they need to provide appropriate care?
Sure, and it's a good question. It's going to be different for even your areas within Indiana because of the subset of populations that occur. We used to do this more globally in the sense of rural health versus urban living, for instance. The population subsets, like I did a lot of work in Philadelphia, and I literally could tell you that I went to this city block, they were all Russian, or if I went to this city block, they were a particular religion. I can do that in the South. One of the best examples of keeping elderly people in their homes was put in place in 1976 by a Jewish community in Bradenton, Florida. And they still have it. It's a block theory that anybody that lives on the block, now there's more than one block, but they retrofitted homes so that people could stay in them. And as the generations pass through, they've kept that philosophy and kept it alive. So, and understanding the aging process, for instance, how we honor elders changes from culture to culture, and highly honored elders in many of our cultures, if they have to go in a nursing home, they're going to expect a respect, for that level. And if our own crew doesn't understand that because we've never been around it, we could be building up barriers that we didn't even expect. So it is now knowing who's in your community. And I don't want to limit it to race and the culture they may have come from, whether they're first generation, second generation, so forth. I think there are other factors that you will understand in your community. There's always shopkeepers and farmers in most of our rural areas, and that's just sort of big ticket categories. The food we choose. The best one I ever saw, Becky, was actually one that had a quarterly meeting on cultural and dietary, for instance, fixed foods, specific to the people that were in that nursing home. Now, for you, it would be the people that are specifically coming into your hospital, because that ultimately would, cover your swing bed patients. But people got to sample food, and it clicked with everybody how different we can approach. Like, I was raised in New England. I do not eat collard greens. I live in the South. Everybody has collard greens for New Year's Eve. Everybody. And they tell me I'm going to have bad luck if I don't eat them. I can't eat them. I was raised on spinach, So we have all these sort of childhood and adult factors that honestly in a swing bed, we don't have 42 hours to figure out the details, which is why we need to maybe more globally get ahead and look at the types of patients we're getting, the people that are coming in, and where we may need to do some training to our own staff once a year, twice a year on that culture, including bringing in a speaker. It may be religious, it may be based on a country, it may be, as I just pointed out, a region in the United States. We have completely different, things going on. I moved from Catholic Connecticut to Mormon Utah. You want to talk about culture shock? When I was a kid, because they're just different ways of approaching life. So is that resounding with anyone, that you are realizing that your communities have changed in the last 10 years? Because I think most rural areas are significantly changing at this point. And how are we teaching our own staff about the differences on staff and in our community, and what does that mean for the care of a patient? Does that help at all?
And let us know if that's helpful to you. It's helpful in answering, some of my questions. I always find it hard to really provide good guidance around some cultural behaviors, just looking out there for good materials and resources. For instance, we particularly recently were looking at building competency around Amish populations.
Correct.
Of course, then there's also a lot of different Amish groups, but just knowing really how to effectively implement a good cultural competency training for your staff can be very challenging.
And Becky, that goes back. Sarasota was it for many, many, many years, probably until the last decade, a majority Jewish community. But in the winter, had a huge input of Amish and Mennonites coming down to spend the winter. And everybody, regardless of religion or background, loved to go to those restaurants. I can tell you that. It's a lot of food, and it's good food. And now they have a mix of foreigners, more Christians, some Buddhists. So just in a decade, the community that has changed significantly. And I suspect we're seeing some changes in our communities. How are we educating our own staff to be aware of the highlights of what those patients may believe? Doesn't mean we have to transform our own belief system. It just means that we're being good partners and understanding who's in our community. I will go back. Boston has a huge population of Christian Scientists. And as you know, in healthcare, that can cause some different difficulties. So they have ongoing discussions with the Christian Science community. So we've had it. We've done it in pieces. What is being mandated, since 2016 really is the increase in how we're training our own staff and what outlets we're providing to each of us. If we don't understand somebody that's coming in, what kind of training do we do then? If we have a growing population, are we talking about what their needs may be? So And for those of you that have to discharge patients, some of these cultures are very, very good at taking care of their elderly, and some that is not a factor in when we're discharging someone. So it goes down to core level, I think, and it's not an easy, like, here's one policy and here's one training program and we're going to be able to handle all this. I think what I'm asking and what the federal government is asking by this is that you show that you are leading the direction of how we are going to train and adjust and pay attention to patients that may have differences.
And just to kind of bring up for everyone to kind of give some thought to as well, we recently had one of our hospitals that they encountered within admitting a patient. They had went through a sex change, and then how to handle the medical record, how to admit them appropriately so everything stayed connected, how to address it. The person was kind of in the middle of their transition, and they really did not have a lot of good policies and procedures around those particular instances. So it was, it was probably not the best patient experience in the beginning, but something to kind of be thinking about, because I think in rural communities, we're going to be experiencing more of those types of situations too.
So Becky, that's a good point in this sense. Not only are we going to see those kinds of changes, but more importantly, we cannot write a policy that's going to cover all of this, literally, one step at a time. This is what we do for so-and-so. So we need a global policy that says that we are training on sensitivities, that we are gathering information at admission from that patient and or family and or patient representative on things that are extremely important in our 1 to 2 weeks, sort of generally, that we're going to have that person in our care. And it's a way for us to learn, and it's also a way for us to pass on information quickly. And there's just not a simple patient anymore in Swingbed. I don't think there ever was, but it's really completely different worlds right now with what we're looking at. And just not only the background of the individual, but obviously the medical conditions of everybody are much more severe than we had a decade ago. So we got a double whammy. So I would look internally. I think the person-centered care and the trauma-informed care, what you put in place for your swing bed would help your whole hospital, honestly. So it doesn't mean, unless you're mandated by certain things, and they may have some training already set up. But I think everybody's going to have to look into those. I'm leaving infection control and prevention off the discussion today because we really know what we're supposed to be doing with that. We have been, the government's been dogged about keeping up with us and finding us and doing all sorts of things. Plus, generally in healthcare, we know what we're supposed to do. It's a matter of us doing what we're supposed to do that gets us in trouble. But these other two areas are so global in one sense and so specific to your facility in another that I think it's worth us having some ongoing discussions about. I will tell you that I've given Becky a larger document that has a little more information in it beyond the case study. And one of the things that to consider is a list at the end of the document she's going to send, which has to consider how you deal with safety, trustworthiness, choice, collaboration, and empowerment, I think is the last one. Mm-hmm. It's from SAMHSA, which is the mental health, I can't remember all the initials, Becky, but it is the Mental Health Leading Association in this country for training, and you will find training on these items out on their website. So if you look up SAMHSA, it will pull right up, for training documents and background information on it. But those are the main categories that they're asking everybody to consider when we are building care plans, when we're admitting patients, when we're trying to deal with tricky situations. What did we do that was specific to this patient in those areas? just the fact that you've looked it up, downloaded material, training on some of it will help you with surveyors because it is a recognized approach. And I think it will give you some plain English to help you translate to everyone on paying attention to how we're treating and even being around patients. When you think about your housekeeping, your dietary maintenance, you know, they're included in the training for these items. So I can see Sue Dee's face, and she's gotten very serious now. So I can't see everybody else's face. So I don't know how everybody is taking to all this information. So either I have stunned them into silence, or they're scrambling right now to figure out if they have policies. So Becky, is there a way to get some feedback to see if what we need to do about this on an ongoing basis?
And just opening up to everyone to comment either through chat or online.
And you can always use the reactions too, Becky, if people are interested in more information, maybe give a thumbs up. You know, if they feel like they've got it, they can give the little red X, something like that. You can always ask those kinds of questions.
Good point, Allie.
Do have a comment in chat. If we have a policy to address quality of care standard 11.11.01 that includes trauma-informed care, is this sufficient? Or do we need a completely separate policy for trauma-informed care?
I do not think you need a totally separate one. What I do think is everybody on your staff needs to know where to find it. That's the turnaround on this. So if a surveyor, because Joint Commission is one thing, but if a state or federal surveyor are walking in, they're looking at CMS and not Joint Commission standards. If your staff knows to direct them to that particular quality standard, then you'll be in good shape. I would review it, make sure it covers the things that you think it needs to be covered. The second point that I will bring up with any policy, and this is true for anything that we talk about in healthcare, is what is your training schedule? These are not things you train when somebody comes in the door and you don't talk about it again. These are ongoing discussions. Trauma in particular, what they're going to look for very specifically, they're going to want to see your logs on the last training all your staff went through. They want to see that it wasn't done just as admission, that you're doing it quarterly, semi-annually, annually. I don't care about the spread. I mean, that's for you guys to decide, but they're going to want to know that everybody on staff has had training in it. And part of that policy for your staff should be, if they run into a difficulty, what do they do? You know, who do they go to in your system to say, you know, this is impacting me? It's hard for people to admit that, first of all. You know, we're also good about talking about psych. Other than TV shows that joke about psych, we very rarely have these discussions when it comes down to a personal level. So we've got to figure out where people can go if a particular patient has set off something within them. And I will go anywhere from pandemics, but when you see the list of trauma and start thinking about it, there are a whole lot of us that came through childhood with childhood trauma, a whole lot of us in the world. There are a whole lot of us that have been through divorces or separations. There are a whole lot of us that have been through poverty or times when we didn't have food. I mean, this is not a one-off sort of issue. It is an ongoing issue for all of us. You may have staff members now in the middle of a divorce that, you know, how we've all had to deal with that. We've had to cover sometimes because those staff members couldn't come in on certain time periods if they're getting divorced. So that it's just bringing the awareness up. And once we have the awareness, where do they go? You know, what is your policy for not doing the Disney way and having them walk out, you know, during a time period? That makes sense to everybody? And I'm sure you have a lot of that in place. Are we very aware of it right now?
Gary, I did have a question chatted to me, and it says, this is a little off topic, but we are struggling with a provider that is concerned about using up a patient's 100 Medicare days by admitting to Swingbed. any suggestion on this particular battle? And that's interesting because we just had a discussion with a hospital
Mhm.
yesterday about it. So if you would like to comment on that too, because it seems like if that question comes up once, we end up having other hospitals.
At least
with that
three,
same type
at least
of
three.
question. Yeah.
It
Yeah.
comes up at least 3 times. It's always amazing. So first of all, the 100 days are to be used in any skilled setting. So I'm going to think the subset of that question may be from a provider who works with nursing homes. And the nursing homes have always been worried about, and I think rightfully, swing bed programs using 20 days up and then sending them to a nursing home. So on the 21st day, individuals still needing Medicare coverage have a copay due. And skilled swing bed programs, one of the reasons we have these short stays, because they're not mandated to be this short, was because many hospitals didn't want to deal with the copay. That's literally been the dividing point. So this may be a provider that's going on in your community, or that may be a provider that has a history of realizing that the nursing homes were getting patients without the benefit of 100% reimbursement, from Medicare from day 1 through 20. That's my first thought. The second thing is literally, whether it's swing bed or skilled nursing facility, the 100 days is the 100 days. And so if they're getting the care they would need, would be the way I would approach it. So if we need more care, more testing, more interventions, in the first, I'll say 8, 12, 16 days, I hate patterns. I don't like to say stay 2 weeks or something, because that gets reviewed very easily. But if that's what the patient needs, then in fact, we're sending them over to the nursing home with the idea that they can be managed better for the rest of the Medicare days available there. Very few stay to 100 days. That's the third piece of this conversation. Medicare changed that in the 1990s, actually, where people were running out through their 100 days, in one stay, one event, and that got changed. So that may be a factor. If we have people that have chronic things like tubes, where that they're always skilled for the rest of their life, then they're going to run out of that 100 days and not get a new Medicare package for skilled care. If they can go 60 days without skilled care, they get a new 100 days, even if they're in a nursing home. If they're in a nursing home bed and not in a skilled bed, they can actually stay off service for 60 days and get a new 100 days. So that's another part of it. So I think, having said that much, if I were working with that provider, I'd like to know what he or she is worried about. Is that, talking about what you just said with change of gender, I'm having to learn how to say what they might be interested in instead of he or she. So I'm having to change my language patterns too. But anyway, what you might want to do is find out what happened there. Is someone routinely using up 20 days and sending them to a nursing home that the provider may be working with? What's the backstory on that? And then maybe we can figure out how to make it better for everybody, provider, more specifically for our patients / residents of nursing homes. Does that help whoever's asking that question?
Yes, they said that was helpful.
Good.
Any other general questions in our last couple of minutes here? Or any other things that you've been struggling with?
We will probably readdress this, not like next month, somewhere within this year, just to see what changes were made, where we still have difficulties, so that maybe we can help each other. I can help provide materials too. This isn't a kind of one-off topic. These are major considerations in delivering our programs.
And there's a comment in chat: with the 100-day reset, must go 60 days without an ER visit also, questioning that.
That's a good question, but I think I have to go back and read the reg. I haven't read it in a long time. I think it's head in the bed days. So it would be 100 skilled days, which means head in the bed, whether it's in a swing bed or in a nursing home. So outpatient services wouldn't count against those 100 days, and ER wouldn't count against those 100 days, if that makes sense.
Okay.
Neither will hospital days, by the way. Hospital has its own, as you know, it has its own set of days. So this is specific to skilled nursing, head in the bed. I know that's a big technical term when I say head in the bed, but it makes it easier.
Another issue that has come up, Kerry, and we actually had a discussion at a hospital is in a small pilot project, we've been looking at readmissions with a few of our hospitals in the state, and other states readmit back to swing bed, and hospitals in Indiana tend to not do that. And also just want to confirm like specific steps that should be evaluated and assessed prior to readmitting back to swing bed. I think there's some hesitancy to do that. So do you have any additional guidance there? We've had some discussions about it in the past, but wondered if there was a good policy that kind of outlined specific steps for readmitting back to swing bed.
Right. Let me start with saying there's a good readmission and there's a bad readmission. The bad readmission is when we send somebody out in 7 days, 10 days, 12 days, out, any number you want, and they have to come back into the hospital because of a medical condition related to what put them in the swing bed in the first place. In other words, something has gone south with that individual. What that implies to the federal government is that we're not keeping our patients long enough in a skilled setting to make sure they can go home safely for at least 30 days is sort of a window that the government, they said 90 days for years, and they've dropped off that, thank God, because we have enough readmissions in 30 to deal with. So if we are stuck on a number, or you have a provider that wants to always discharge somebody by 10 days, for instance, regardless of whether they still need some assistance, learning how to inject, whatever it might be, or that they're still, I'm talking about all these respiratory diseases, sending people home with respiratory distress is going to bring people back into the ER and or hospital pretty quickly, because all of us have had some example, even if it was the wind knocked out of us, where we couldn't breathe, and it is frightening. So the bad one is where we haven't kept somebody long enough to make sure they were stable enough to stay at home within reason. I mean, they're elderly and they're going to have problems. The second piece is that the government has always allowed, CMS has always allowed readmissions within 30 days. My best example is really to set up conversations with people that are going home. And the best example, the easiest example I can give you is, how many of you heard an elderly husband or wife swear from day one they can take care of their spouse at home? And there's reasons for that. One is really psychological. They're scared to death that they're going to be put in a nursing home by their family, that they're going to be taken out of their home, that they're going to be separated, thousands of really realistic psych issues. So they want that spouse home with them, and not for bad reasons. I'm not saying for controlling reasons, but because they want to stay where they are in that, relationship as long as they can. And so it's fear. And you have been in those discussions when you go to IDT and when we're getting ready to discharge, where that 104 pound wife swears she can lift the 6'6" guy out of bed and get him to the bathroom every night. And I'm only slightly exaggerating that example because we have it day after day. So to me, one of the things you can build into your discussion, and using this as an example, is, look, we understand you wanting to go home. Basically, this patient's doing well, but he or she's going to need what? A, B, and C, whatever it is. Meds 24 hours a day, getting out of bed to go to the bathroom, whatever you can give that's true. So we'd like to remind you, offer you, whatever you want to put the language, that if it does not work out in those first couple of days to a week at home, he or she, they can return to the swing bed program. And we will continue the care until we feel like, and you feel like, we have them as safe as we can get going home. That gives them an out to take somebody out early, which is not what we really want, obviously, let alone the paperwork, but it does give them an out so that they're not having a fall or something's where they're having to call an ambulance because they're got a critical condition now and returning to the hospital. So that's the first value of it. The second value really is overall people, for instance, with orthopedic is one example. I always use cardiac and respiratory as others, where they get home and they have a dip, where they were doing well, and then they have a couple of days where they're not doing well, and they're either frightened by it or it's significant enough, maybe the meds need to be adjusted, whatever is going on. And if we say, this can happen with this particular disease process, illness, whatever is going on, and if you need help, please contact your provider, go to the ER if you need it, but know that you can return to the Swingbed program within 30 days of discharge if we need to do some additional changes of meds, training, whatever else you might do. Does that make sense to all of you that have to put that into English with people sitting in front of you?
And so what steps do you recommend a hospital takes when they're readmitting that patient?
Well, I'll back it up to when they discharge. I think part of your discharge note would be then, because of the complexity of the COPD or whatever else is going on, that we have educated the patient and patient representative, family, however you want to put that, on the possibility to return within 30 days, because now you're defining it as it was an option. It is not a penalty, for them to return within 30 days in this setting. And so when they are readmitted, then that changes your readmission. It changes your readmission to, this is an ongoing problem that we recognized in their first skilled stay, and here's what we're going to address. To, this is a new complication, a deeper level of whatever the disease process is, which really is why, readmission should occur when we're talking about hospital stays. So I would define what is the basis for the readmission. And I think that will help you not getting out of the eye of a hurricane with the federal government on readmissions, but you can start saying, look, 30% of our readmissions were because of elderly patients and need for additional education, training, and safety. Safety, remember, safety and quality of life. Those are the two main reasons we have a skilled level of care: safety and quality of life. If you can mention those when we're admitting people, when we're readmitting people, when we are, particularly if your social worker is involved working with them, that's why we have it. This safety goes to the healthcare issues. The quality of life means, can they reside by themselves? Are they able to go home? And people do heal better, in their own surroundings than they do in a hospital bed generally. So if you can use those terms, that will also help us on surveying going forward. I think it just helps families and patients start realizing. And I will say the third thing that comes up is you've got a whole lot of families that are not ready to take care of mom and dad. I've had this discussion with my kids, and they keep looking at me and saying, "Oh, Mom, you travel all over the world." Well, I may not be doing that tomorrow. I may have a stroke, or I may have whatever. But they're thinking I'm going to be independent until I'm 190 years old in their minds. They don't see it. And I've said, here are my papers, here's this, and they go, thanks, and they don't want to talk about it. We have an awful lot of families, particularly as we have a lot of elderly aging well, hiking and traveling and doing things into their 80s and early 90s. We didn't have that a decade ago. So I think we have that societal adjustment in our own communities, and that's education at some point. That these guys may need to come back in because how many of you have heard the family say, we can take care of him, we'll come to the house? They're not there all night. They say they will be, but they go home at night, to their own families. And that's when we have falls and so forth. So I think we need to document shorter than I just explained that whole thing, but certainly list the sentences that show why there is concern and need for readmission, medical and support-wise.
Okay.
So I will say this, most of the country is using it to some extent. It is not widely used. It's not something you're doing with every patient, but it does have its place. And I think it would behoove all of your programs to stop and in IDT meetings, even if you're discharging somebody, realizing this may be somebody that needs to come back, You know, and that starts opening your minds to what does that mean and what are we going to have to do?
Okay. Thank you.
Yeah, I
We're-
just preached.
We're over on time a little bit today and apologize for that. Kind of lose track of time when we get talking about all this. So if you have other questions, why keep them coming. Glad to assist and glad to take some time to meet with your programs individually to talk through any issues, concerns, or questions that you're having. So please reach out, and want to thank Allie Orwig from the Indiana Rural Health Association for supporting Zoom for us today. And thank Kerry Dunning, as always, for all of her expertise and guidance. And so we look forward to our next meeting in February. So stay well, everyone. Thank you.
Thank
Bye-bye.
you. Bye-bye.
Bye.